Welcome to this explainer. Today, we're jumping right in to crack a super common, yet potentially high-stakes clinical mystery, unilateral leg edema. Basically, one swollen leg. We're going to equip you with a rapid, reliable mental model for clinical diagnosis when a patient presents with this issue. If you've ever felt completely overwhelmed by the sheer number of possible causes for swelling, well, you are in the exact right place. By the time we wrap up, you'll have a rock-solid, step-by-step framework to navigate this challenge like a pro.
So let's dive into this by starting at the ultimate fork in the clinical road. When you first look at your patient, you literally just have to ask the simplest, but honestly, the most crucial question. Is it one swollen leg or two? I know, it sounds almost too basic, right? But this single observation instantly slices your list of suspects right in half. It really is the absolute foundation of our entire diagnostic investigation today.
Here is our roadmap for today's explainer. We'll start with the one-leg mystery, meet our DCLI lineup, break down the primary and secondary suspects, explore our clinical toolkit, and finish up with the ultimate safety drop.
All right, Section 1, the one-leg mystery, the fork in the road.
Let's start with the master rule that divides our investigation right from the very first glance. Two swollen legs? Well, that usually points to a systemic failure. Think about the heart, the kidneys, or the liver struggling to manage volume and proteins across the whole body. But today, we are exclusively walking down the local pathway. One swollen leg means a local problem. We are zooming in on a localized issue that is confined to that specific limb.
Moving on to Section 2, the DCLI lineup, introducing the suspects.
Now, let's actually meet our specific lineup of local culprits responsible for unilateral edema. I want you to lock this mnemonic right into your memory. When you see one swollen leg, your brain should immediately flash DCLI. These are the exact four suspects we need to interrogate when cracking this case. D is for deep vein thrombosis. C is for cellulitis. L is for lymphatic obstruction, and I is for injury. Every single time you see unilateral swelling, just run these four culprits through your head.
Okay, Section 3, DVT and cellulitis, the primary suspects.
Let's interrogate our first two most urgent suspects, starting with the one you literally can never, ever afford to ignore. The crucial takeaway here is this. If you see these visceral clues, a single swollen, painful, and warm leg, you absolutely must assume it is deep vein thrombosis, until proven otherwise. DVT is by far our most dangerous suspect. A blood clot in the deep veins of the leg can actually break off and travel straight to the lungs, which is totally life-threatening. So this specific equation, it's your absolute red alert.
To catch a DVT, you really have to look closely at its modus operandi. We are specifically checking for triggers here. Has the patient had recent surgery or been immobilized in bed? Do they have a history of cancer or maybe a previous DVT? Have they been on a long flight or are they pregnant or postpartum? Hormonal risk factors also play a huge role here. These triggers are basically the smoking gun that raises your clinical suspicion for a clot.
Shifting over to our next primary suspect, cellulitis leaves behind some very loud, obvious clues. It is distinctly red, hot, and painful. This bacterial infection of the deep skin tissues is typically unilateral, and the skin is going to be super red, warm to the touch, and really tender. Sometimes it's even accompanied by a systemic fever. Now, it definitely shares some overlapping features with DVT, like that pain and warmth, which is exactly why your investigation has to be so incredibly precise.
Let's jump into Section 4, lymph and injury, the secondary suspects.
Next up, let's examine the unique clues left behind by lymphatic issues and physical trauma. Lymphatic obstruction might sound a bit like a terrible dating profile. You know, large, chronic, and firm, but it's actually a fantastic clinical clue. If the swelling has been there a long time and feels incredibly firm to the touch, you're likely looking at a lymphatic issue. This is really often linked to an underlying malignancy, previous lymph node surgery, or perhaps radiation therapy. It essentially builds up over time and just radically changes the texture of the tissue itself.
Our final suspect in the DCLI lineup is simple injury. Honestly, this one is usually the easiest to catch because, well, the patient's probably going to tell you about it. Straightforward trauma directly leads to the swelling. We're looking for things like fractures, sprains, muscle tears, or just direct blunt force trauma. If there's a clear history of a sudden physical impact followed by swelling, injury is absolutely your prime suspect.
All right, Section 5, look, feel, ask, test, the clinical toolkit.
So now that we intimately know our four suspects, let's see how this actually builds into our physical exam. This straightforward sequence perfectly walks you through the chronological action you've got to take to systematically catch the culprit. First, you look. You assess for redness, symmetry, and skin changes. Second, you feel the tissue. Third, you ask targeted history questions. And finally, you test to confirm. Let's break down a couple of these specific tools right now.
Now, the most fascinating tactile difference happens during the feel step. This is a total game changer. Pitting edema means when you press your thumb into the skin, an indentation temporarily remains. That points directly to fluid buildup, often venous or systemic. But non-pitting edema, it doesn't leave a dent at all. It forcefully holds its shape. And remember our suspect profile from earlier? Lymph doesn't leave a dent. So if it's non-pitting, your lymphatic obstruction suspect just shot straight to the top of the list.
When you reach the ask step, you really want to structure your interrogation around the time, trigger, and system methodology. It's brilliant for exposing the root cause. Ask about the time. Did this happen acutely today, over a few days, or has it been going on for months? Ask about the trigger. Has there been any surgery, long travel, or trauma? And finally, ask about the system, looking for clues outside the leg itself, like breathlessness or jaundice, which might actually pull you right back toward a systemic issue despite that unilateral presentation.
And that brings us to Section 6, the ultimate safety drop, your clinical tripwire.
As we wrap up this explainer, we absolutely must address the ultimate safety tripwire in our investigation. If you take away nothing else today, please remember this most critical safety point. A suddenly swollen, painful leg demands immediate diagnostic action to rule out a blood clot. You simply cannot sit on this. You cannot just wait and see. DVT is literally the ticking time bomb of unilateral leg edema.
And that leads us to our final, somewhat provocative thought. The source material is completely clear on this. Clinical examination alone cannot reliably exclude a DVT. So, if your own eyes and hands cannot entirely rule out our most dangerous suspect, are you ready to trust the tests? You really have to be prepared to move past your own senses and deploy the proper diagnostic pathways, like the Wells score, a D-dimer, or an ultrasound, depending on your clinical probability. Your mental model of DCLI gets you to the right neighborhood, for sure, but it's the objective tests that actually lock the suspect in handcuffs. Thanks so much for joining this explainer, and happy diagnosis.